Good evening and welcome to another Back to Basics Facebook Live, a series where we ask a speaker to take a subject, strip it back, and then take us through it step by step. Tonight it's a second of our week double bill, and we are joined by Jackie Locke. Jackie is the Programme Lead at Glasgow Caledonian University, and Jackie's going to be taking us through a whistle-stop tour and an introduction to local anaesthetics. Now, this is part of a slightly bigger course that we're going to be running over the next month, which you can take part on. If you go into our Facebook page, you can find the link there and sign up. It's £25 for 4 parts, and that will be a count towards your full 3 yearly LA update. So if you do want to find out more, or if you've got any questions, do ask. We also love to have your questions for our speakers. So if you do want to ask our speakers any questions, do check in, put them on the comments in the Facebook page. If you're on a watch party, your best option is to go to slido.com and use the code BACK2BASICS. That's BACK2BASICS with the number 2 in the middle. You'll also be able to use another device if you've got one to be able to take a picture of the QR code on screen and be able to link to it that way. But I know Jackie's got a lot of stuff to get through, and I'm catching him just putting in a quick glass of water to get ready for his presentation. But it gives me great pleasure to welcome, and particularly from this parish, Jackie Locke. And over to you, Jackie.
Thank you, Michael. Good evening, everyone. Ordinarily, I would start a talk by saying, nice to see you, but I can't because I can't see you. I don't know who is out there. You can see me, I hope, and if you can, you will know that I am not one of the vast majority of the country who is desperate for the hairdressing salons to open. But thank you for being here tonight. Thank you for taking time out on what is a beautiful evening. And hopefully, as we go through this session, you'll benefit from it. Just at the very outset, just to declare no conflicting interest in anything that I speak about over tonight or the next few weeks. I was responsible for authoring the NHS Greater Glasgow and Clyde Local Anaesthetic Nail Surgery Guidelines 2013. They were submitted as part of the process in compiling the College Nail Surgery Guidelines. I submitted personal opinion at the early stages of the above consultation process. So I just want to make that declaration at the beginning of this talk. I think also what I would like to do is just take a moment to say thank you. Thank you to all my colleagues who have been over the last 10 weeks involved in the continuity of patient care. It's not an area that I have been involved in, but I think it is right and proper, and I want to just acknowledge your valuable contribution in these difficult times over the last 10 weeks or so. I was supposed to be doing an update day back in April, where ordinarily we would have got together in a room and I would have stood at the front and been able to talk with you. And unfortunately, that's not now the case. And a session that should have been like that now looks something like this. And as I look at that photograph, I look at my posture and I realise now why my back has been so sore over the last few weeks, and also realise that my wife's home baking has had more effect than at first I realised. So delivering sessions like these can be quite challenging because I miss all the non-verbal feedback that I get when I would be speaking to you in a room. I miss the expressions of not quite understanding or wanting to ask a question but not quite going to do that. And from this side of the camera, I've learned over the last few weeks in trying to deliver some undergraduate education, it's quite demanding and it's quite tiring and it's quite different. Trying to teach the eccentric function of the quads and the hamstrings through a webcam in this office was somewhat difficult and somewhat challenging, but it gets you to think a little bit more innovatively. But also, earlier on this month, I was on the other side of the camera, and I was a student for a week on a course. And it's actually really difficult from your side of the situation as well, because concentration can be quite difficult and focus can be quite difficult. And so I acknowledge all these things, and I hope that as we go through this that we can learn something together in the topic of local anaesthetics. I have always enjoyed doing local anaesthetic updates. I've done quite a number over the years, and the reason that I enjoy them so much is that I always learn something new. There's always someone asks a question that I don't know the answer to, and I've got to go and find out. And there's always someone shows up who's read an article and they're not sure about something, or they can pass on new information that I didn't know. So I enjoy these, and I look forward to learning something from the questions and contributions that no doubt will come my way over the next few weeks. But I think it's important to stress that as we go through the next tonight and the next 4 Wednesday evenings, for those of you who have signed up for that, much of what we will be talking about is material that you already know, you're already familiar with, you've already learnt it. And really my role is just to refresh and to remind and to try to help you to build an understanding and build a confidence and just refresh your memory. And primarily what I want to do is just build confidence with you in your use of local anaesthetics. Let me talk to you just for a minute or two about objections to using local anaesthetics. Now, these are of course anecdotal. These are phrases that have been said to me at various times as I have done local anaesthetic updates. Some of them are legitimate, some of them I think are maybe not so legitimate, and I'll leave you to decide which ones are which. But on a number of occasions, someone has said to me, I just don't use it. And I asked the question, well, why? And the normal response is, well, I just don't. And I think when you get that type of response, there's probably something underlying that, whether it could be somebody who has a fear of using needles and syringes, a bit of a phobia, or it could be lacking of confidence, I don't know, but that is often a response that has come back. Then there is, my scalpel skills are so good, I don't need to use local anaesthetic. And I trust that if that's an opinion that you have, you're completely unfazed when you go to the dentist for root canal treatment. And the dentist, of course, says, well, my drill skills are so good that I don't need to use a local anaesthetic. Some people have just the way that the clinics that they've worked in have been structured, feel they've been restricted by appointment times. Others, it's about uncertainty and lack of confidence, perhaps not sure about working as a lone practitioner, not sure about the protocols for house visits, or not sure about techniques other than doing digital blocks, which are the most commonly used. And hopefully we can address some of these issues over the next few weeks. And some would say, well, really it's a sphere of practice that I'm in that I don't really need to use local anaesthetics very often. So it's not that I've got anything against using them. It's just that the type of clinics that I work in, it's not something that I routinely ever have to do. So perhaps you fall into one of these categories. But what I want to be doing over the next few weeks is looking at building confidence. And I think there are 4 key areas that probably I want to consider building confidence. And the first is in safety. Plain solution local anaesthetic drugs are very, very safe drugs to use. And I would go even further than that and say plain solution local anaesthetic drugs are very safe drugs to use, especially in the context of podiatric practice. And we'll look at why that's the case in a couple of weeks' time. But then I would want to build some confidence in adaptability. Now, what I mean by that is that local anaesthetics are not just for digital blocks for nail surgery. It is, of course, the most common use of local anaesthetics and podiatry, but there's almost an unspoken association between the two, that when we talk about local anaesthetics, we're almost automatically talking about nail surgery, and that's not the case. It's of course the context in which we were taught, and it's a good context in which to be taught, and it's a very useful context because it just works clinically. It's a logical situation to learn. But when I'm going to be talking about local anaesthetics over the next few weeks, I'm going to be talking about the bigger picture of local anaesthetics, and not just about being used in the context of nail surgery. Now, I know that recently Ian Riley was in this forum, and I know that he spoke about a whole variety of uses of local anaesthetics over and above digital anaesthesia. So I don't intend to per se go over these again. I'm certainly not going over them tonight. But if anyone would like more information and a bit of refreshing on that, I can pick it up in another session if you so wish. And then I want to build confidence in emergencies. And you say, well, why are you talking about emergencies if you've just said that local anaesthetics are essentially very safe drugs? Well, they are very, very safe drugs, but there is the very small possibility that there can be a drug-related clinical emergency. And even though the possibility is very small, it is something that we need to be aware of. It's something we need to know how to recognise, and it's something that we need to know how to manage. So we're going to dig underneath the surface of these drug-related clinical emergencies, probably in the last session, and hopefully build confidence that you can recognise, that you can differentiate, and you can manage these clinical emergencies. And then I think, finally, what we want to do is really build confidence in clinical decision-making. Because what we want to do over the next few weeks is gain a broad understanding of local anaesthetics that will help you to think clinically and help you to think of how to problem solve when the anomalies arise, when the patients arise that are not quite straightforward, when the patient has a medical history or a drug history that we're not quite sure of what to do, and the associated risks, that we can actually start to problem solve. And I want to build confidence in problem solving. So over the next 4 Wednesdays, I have pulled together a programme. This is the planned programme. Tonight is about back to basics. And just while we're talking, have a think about what is the back to basic of local anaesthetics. What is the baseline knowledge at a very core level that we need to understand? There are several areas. I'm going to pick up on one very basic one this evening. And then next week, I want to look at physiology and pharmacology. So we're going to take an overview of the nervous system as a whole. We're going to look at nerve conduction. And we're going to look at a simple, understandable level, the pharmacology of local anaesthetic drugs. We're going to look at understanding how they work. Now, very, very interestingly, when I have done sessions in the past and they have been evaluated, that topic, the physiology and pharmacology session, is actually one that evaluates the most. It's the one that people say, I had forgotten all about that. I've not looked at that for years, and I found it really interesting and it refreshed my memory. So hopefully next week, that'll be a good refresher for everyone. The following week, on Wednesday, the 10th of June, I want to look with you at drugs and doses. And within that, we're going to look at the drugs that we have licensed to use in podiatric practice. We're going to look at maximum safe doses, how to be confident in calculating maximum safe doses, looking at actual doses, administered doses, and how to make sure we know how to do those calculations. And then I want to look at multi-dose calculations. The more we use local anaesthetics, then perhaps the more complex things we're doing with them, and we need to know how to be safe and have confidence in calculating multi-doses. So we'll look at that as well. And then following, we're going to look at contraindications and considerations. Contraindications, when you just don't give a local anaesthetic. You may be surprised, but I don't think that section will take particularly long. What will take more is the considerations, thinking our way around about medical history, drug history and such like, and the things that are worth considering in a patient as we come to give local anaesthetic. And then the final session, we'll look at clinical emergencies. We'll delve into a bit of detail about toxicity, drug toxicity, and how to recognise and manage it. And we'll look at allergic reactions and anaphylaxis and try to understand what is going on in the body during an anaphylaxis and understand how then we need to manage that. So that takes us to the 24th of June. Following that, I should have been joining this nice ship for a 2-week cruise leaving from Venice round about Croatia and Greece and Italy. Unfortunately, that is not happening, but I'm still going to take some time out. And what I would say to you is that in that intervening period, if there are any things that we've not managed to cover in these 4 sessions, or if there are any other specific areas that I've not dealt with or questions that you want to deal with, then I'm happy to pick up, and I've said to the committee, I'm happy to pick up another session or 2 at a later date, just to make sure that all the eventualities are covered. Any specific subjects, again, please pass them to Michael and I'll try to address them certainly over the next couple of weeks. Last year, the college produced these guidelines. I don't know if you've read them or not, but if you haven't, I would urge you, before we get into next week's session, to read them. I think they're a very, very helpful document. I think they are designed to assist in clinical decision making. So there's a good overview, particularly of nail surgery as its primary focus, but there's good stuff in there about local anaesthetics. But when you're reading it, try to read it critically. Do you agree with everything that it says? If you agree with it, why do you agree with it? If you disagree with it, then why do you disagree with it? Are there any controversies in it? Any things that you think differently? Any questions that are arising? And I think from a good critical reading of these guidelines, it could inform some good discussion and good debate. But I do think that the college have done a good job in producing a guideline that is there to certainly help and assist in clinical decision making and clinical practice. So, back to basics. Before we go on to this, let me just take a drink of water. Thank you. So, I was on Twitter the other night and I saw someone had tweeted this. I'm not a great engager with Twitter, actually. I go on and off it periodically, but I saw this and I thought it was very, very interesting. And it said, give me a horror story from your own speciality in 5 words or less. And the first post that I saw on it, or the first response I saw, and there were hundreds, was from Gordon Henry, who may well be known to you. I don't actually know if Gordon's on tonight, but I thought this was fabulous. From a senior researcher, a horror story for him is P equals 0.51, and I can imagine why that's a horror story. Then this one came up and I thought was, yeah, I get that. Asymptomatic person-to-person transmission. We get that, don't we? And then as we're into this virtual world of meeting now, you realise your mic is on, and that could be pretty horrendous. Not so horrendous as this one. You realise your camera is on, and I'm sure you've possibly seen some funny clips on social media of when that happens. Another one I saw that resonates strongly with me is it in the exam? And of course we're trying to encourage students not to learn for exams, but actually to learn for their career. But for me, I think this would be my horror story. Don't know my nerve anatomy. And it's a recurring thing thing that comes up actually in teaching students, and particularly undergraduate students in teaching local anaesthetics. But it's not exclusive to undergraduate students. Very often at the start of a local anaesthetics session, I would give out blank sheets of paper, and I would ask the delegates to draw a foot and a leg and to chart the nerve anatomy. And some of the looks of horror that come my way are quite significant, and some of the end products are a little bit scary. At the start of every first year, the very first anatomy lecture that I give, I show them this picture. And that picture is the cockpit of an Airbus A380. And I asked the question, how many of you would be happy to fly on this plane with a pilot who didn't know what every light, dial, button and lever was for? And there aren't many who would confidently walk onto that plane without the confidence that the pilot actually knows what all these things are about. About 6 weeks ago, my boiler broke down. It had a leak and it broke down, and I managed to get an engineer out, and he charged me 95 quid for a half-hour visit. Do I expect him to know every part of that boiler and how it functions and what it does? Yes, I absolutely do. So I defend the decision that if we claim to be experts in the foot and the lower limb, then we need to know it in detail. And that includes often the forgotten aspect of nerve anatomy. It was only last night, again on Twitter, having said I'm never on it very often, 2 quotes from Twitter. This came from Ewan McGivern, who will be known to most. Ewan, if you're out there, I thank you for that tweet that was put on last night. And I think this captures the essence of what I'm trying to say really succinctly. It was on clinical skills of podiatrists, and Ewan, I quote, says, back to framing the core clinical set of the podiatrist: anatomy, physiology, pathology, biomechanics, pharmacology. If any of these are missing, we are not fulfilling the role at any grade, in my opinion. Then add the technical tasks. And I would endorse that. That would be my opinion also. And I think that's why I'm looking at anatomy tonight. And we're going to be looking at physiology and pharmacology next week. These are the core base skills that we need to know to be able to do good anaesthesia and to understand what's going on and be able to problem solve. Now, I've talked long enough. I'm going to take a quick break, 2 minutes, and probably less than 2 minutes. But I want you just to take a moment to answer these 4 questions. How many nerves pass the ankle? What are they called? Where do they pass the ankle? And where do they provide sensory innervation in the foot? It's not a test. I won't know your answers, but I just want you to take a moment to collate your answers, and we'll go through them and talk about them. Because this evening I just want to talk with you briefly about the nerve anatomy of the foot and ankle. So 2 minutes is a very long time to sit in silence. That was 45 seconds, and my patience has already run out, and perhaps yours has as well. So how many nerves pass the ankle? Well, if you've said 5, that was good. That's what I was hoping you would say. What are they called? Well, we'll look at them in detail in a moment or so. And we'll look at where they pass the ankle, and we'll also look at where they provide sensory innervation to the foot. Because if we want to be good at administering anaesthesia, then it's important that we have a real good knowledge of where the nerves are situated and also where they function in sensory innervation. So let's just briefly go through this for a few minutes. We'll start with the tibial nerve. It's called by many the posterior tibial nerve. I won't go overly pedantic, but technically I believe it is the tibial nerve because there is no anterior tibial nerve. But if you use the posterior tibial nerve, that is absolutely fine. And of course, it is coming down the posterior aspect of the leg. It's giving motor function to the posterior muscles of the calf. And it's passing the ankle posterior to the medial malleolus. Now, it's also important to note, I don't know if you can see my cursor on the screen, I hope you can, I've not got the area circled, but if you look at where the posterior tibial artery runs, you'll see that the nerve, which is in yellow, sits just slightly posterior to that. And that can be an important marker as well. We'll talk about that in a moment for giving a good anaesthesia. We'll talk in a moment, just in a few seconds, about the branches of the tibia as it goes into the plantar aspect of the foot. But you'll notice here we've got a bifurcation, and this bifurcation is the bifurcation of the calcaneal branch. And very often, if you are perhaps trying to give a tibial block, and the calcaneal branch is perhaps not anaesthetized, it may be that you've injected too far distally and need to go a little bit more proximally, because if you're injecting too far distally, you may miss that branch and not be able to anaesthetize the heel. So that's just a little anomaly that sits there that's worthy of consideration. A tibial block is a fantastic block, possibly an underutilized block that covers the whole plantar aspect of the foot. But if we come into the plantar aspect of the foot, I hope you can see this clearly. We've got three branches of the tibial nerve. We've got the medial plantar, the lateral plantar, and the calcaneal. And I've tried to just divide them up rather crudely here. The medial plantar innervates the medial aspect of the plantar foot, and the medial 3.5 toes. So these 3 digits and this medial aspect of the fourth. You'll see too that there are, the way it divides, there are branches going in between all the metatarsals, so you know they're situated there if for any reason you need to go in between metatarsals to do any anaesthesia. And then we've got our lateral plantar nerve, and it would innervate the lateral aspect of the plantar foot and the lateral 1.5 digits. And then we have our calcaneal branch, which of course innervates the heel. And then anteriorly, we have our superficial and our deep perineal nerves, or deep fibular nerves, as they're commonly called. And we can see here superficially, we have the superficial perineal nerve, and it splays out all over the dorsal aspect of the foot. It's not just so clear, you'll see it better in the next slide, but we have our deep perineal nerve, which comes here and sits in between the first and second digits, first and second metatarsals, just at that web space. Of course, the difference between a deep nerve and a superficial nerve is that the deep nerves lie deep to the retinaculum. So the tibial nerve lies deep to the flexor retinaculum, and this deep perineal nerve lies deep to the extensor retinaculum. If we come over to the next slide, we'll see here, this is where our sensory innervation for our deep perineal nerve is, and the rest of the dorsal aspect of the foot comes from the superficial perineal nerve. And then on the lateral aspect, coming posterior to the lateral malleolus, is our sural nerve, and our sural nerve comes into the lateral aspect of the foot and provides sensory innervation to the lateral border of our foot. And then on the medial side, we have our saphenous nerve, an extension of the femoral nerve that passes just sort of anterior to the medial malleolus and into the medial longitudinal arch, and provides sensory function in the medial longitudinal arch. This is a nice little slide that just gives the sensory innervation of the foot. We can see that clearly in the different zones. It's nicely labelled here. We've got our superficial perineal nerve on the dorsal here, the majority of the dorsal innervated by that nerve, apart from the first second web space, which is our deep perineal. And we can see here just broaching on slightly onto the lateral dorsal aspect of the foot is our sural, and then this medial aspect, medial longitudinal arch, is our saphenous. And then in the plantar, our calcaneal branch of the tibial nerve, our medial plantar branch, and our lateral plantar branch. And again, our sural and our saphenous clearly identified. Now, in these sessions, I don't really have I haven't planned to talk through injection techniques. I don't have a model foot at home with me. I don't have syringes home with me to actually try and demonstrate. It might be quite difficult. But if you want to learn more about good injection techniques, I point you to Stuart Metcalf and Ian Riley's book. It is a good book, and it comes with a DVD of injection techniques of the foot and ankle. It's a book that I once owned. I gave a loan of it to a student, and it was never returned. I don't know who the student was, but I'm sure the student knows who they were. It was a number of years ago. If you're out there, then it would be nice to have it returned. But if you're using it, it's okay. But it's a good book, and it's a good DVD and gives good basic instruction on injection techniques. So whilst I don't really have time or plan or have the capacity to look at injection techniques in any detail over the next few weeks, I would point you to that book if you wish more information. But let me just give you a couple of things just to consider. These superficial nerves, they can be anaesthetised just by very superficial infiltration. They don't sit deep to the retinaculum, they sit just deep to the skin, and they can be gained by very superficial infiltration of local anaesthesia drugs. Be careful if you are anaesthetising the saphenous nerve. It does sit in close proximity to the long or to the great saphenous vein. So just be careful with the positioning of your needle tip in the event of any piercing and any injury to the great saphenous vein. And another thing that, again, this is, you'll find that in some books and texts that talk about technique, certainly would be my own experience, that when injecting the sural nerve to try and anaesthetise the sural nerve, I have found that injecting below the level of the lateral malleolus is probably more painful for the patient than injecting more proximal to it. You may not have found that if you do it, but that is just one of my observations. The deep nerves, they are more difficult to locate accurately, of course, because they do sit deep to the retinaculum. Often nerve stimulators can be used to identify their location, and I know that currently much work is being done in local anaesthetics with ultrasounded guided injection techniques. But what I would say for a tibial block, locate your posterior tibial pulse. Now, when I'm doing it, I use a Doppler and get the pulse with the Doppler. And if you go back and think about the slide with the anatomy where the nerve is sitting just slightly behind the actual artery, if you get the pulse with the Doppler, and actually you can mark the skin just with the imprint of the Doppler, and just go in slightly behind that, then the chances are that you are getting your tibial nerve. And of course, it's important that you're aspirating. And if you aspirate blood, then just again move slightly more behind where the artery would be, and you're more likely to be getting accurately at the nerve. I would tend to aim my needle towards the 5th metatarsal head. If the tip touches bone of the malleolus, I would just withdraw slightly. But again, different texts and different methods. There are a number of good acceptable methods out there. Might say things slightly differently. Your practice might be slightly different. I've seen all sorts of practice, all effective and all safe. But that is just the technique that I would use. For a deep perineal block at the ankle is an injection that I haven't ever had occasion to do, but you're really looking to locate the tendons of extensor lucis longus and extensor digitorum longus, because the nerve runs between them, and you would be needing to insert the needle approximately 1 centimetre deep between the tendons at the malleolar level. Again, making sure as always that you aspirate so that you are aware if you are in a blood vessel and can move your point of injection. One point of note that I've read in several texts is that you need to be careful not to go in too far, because there is the potential that you could inject intra-articularly. So a method of avoiding that is dorsiflexing the foot ever so slightly, just to close off the ankle joint and prevent the risk of intra-articular injection. So that's a whistle-stop tour of anatomy, but it is core and it is basic and it is fundamental. If you want to do good local anaesthetic injections that are effective and minimal discomfort for your patient, then it is important that you know nerve anatomy. So I hope that if nothing else tonight has stimulated you to go and read and revise your local anaesthetic nerve anatomy. So for those of you who are joining us next week, there are some things that I want you to do in advance. I want you, as I've said, to read the college guidelines. They are there, they're on the members page. They can be downloaded in PDF if you don't already have them. And I just want to ask you some questions as you go through reading them. Do you agree with everything that's written? Are there any aspects that you think are controversial? Are there any aspects that perhaps you weren't aware of, that you were surprised at? Are there any things that have come out of these guidelines that you wish me to specifically try to address over the next few weeks? And finally, revise nerve cell anatomy. I'm not talking about the gross anatomy that we've looked at this evening, but a more micro level, just the anatomy of a nerve cell. Have a read round about an old physiology text that you may have lying about, just on nerve conduction. The word action potential may fill you with fear from your undergraduate days, but we'll have a little look at them again next week. And if you've got any questions on physiology and pharmacology, then please jot them down, or please get them to Michael so he can get them to me, or ask them next week, and I'll certainly do my best to answer them. So that's me through the 28 slides that I have. I hope that it's been at least helpful in your nerve anatomy. I hope it's given you an overview for those that are joining over the next few weeks, a roadmap of where we plan to go with these sessions, and I hope it starts to stimulate your interest and, more importantly, build confidence in the use of local anaesthetics. Thanks, Michael.
Jackie, thank you very much. As always, we seem to get an awful lot of love for our speakers coming through the comments on Facebook across all of the different aspects. But I think today that was a really good overview of the nerve anatomy, and I think has been attested to on a couple of times. Knowing that anatomy is just so vital, not just to our diagnosis skills, but also our ability to carry out our practice effectively. Couple of questions coming through, one or two coming through from a young whippersnapper called Ian Riley, but I think you're going to be covering most of his a little bit later on. So for those that have signed up to the course, you'll be able to find out all more about maximum safe dosages, drug calculations, and the differences between the different drugs that we use. But there are a couple coming through. If I can quick reminder to anybody that is online, please do ask us questions. You can do so either on the comments section or you can do so on slido.com. You can do that and putting in the code back to basics. Also, for those that are on the course, as Jackie mentions there, we have sent out an email today to everybody, to remind them about tonight, but also to let them know that we'll be sending out details over the next couple of days, over the weekend, of how to join the webinars. But we've also started a Facebook group there for you so that everybody on the course can get to know each other a little bit, share questions, and also so we can put some resources. So I'll find those, I've got the nail surgery guidelines, I'll pop a copy of them up on there for you so that you don't have to look for them, and a link also to the site. As I say, if you want to watch party, please do use Slido, because sometimes I'm afraid I don't see those questions till a little bit later. Welcome back to John Popaduke, who's got our first question of the night. And that really was a little bit of a question, Jackie, about when you're putting in local anaesthetic, particularly for the nervous patient, would you recommend using a self-applied anaesthetic cream, or would you use an anaesthetic spray just prior to application?
It's not something that I routinely do. I try and build confidence for the nervous patient just by building rapport with them. But I think, I suppose there's a lot of psychology in it, and I think my understanding of these EMLA type creams is that they have to be applied a significant amount of time before the injection to actually be effective. So if they're applied significantly before, it may make some difference. If psychologically it's going to make a difference for the patient, then there's no harm in applying it. It's not something that I routinely do. I would try to talk with the patient and talk about the technique that we use. I would try to reassure them that the equipment that we would use would have the finest bore of needle, that the techniques we use are designed to minimise the patient's discomfort, and just try and build confidence that way. I think where I have used sprays in the past would certainly be with children who are nervous. Again, I'm not sure of the evidence that actually alters the level of the pain, but I think it's a distraction. It gives them another sensation to consider. But I don't routinely use these types of creams and these techniques with nervous patients. I would rather build their confidence and actually almost rise to the challenge of trying to get them to overcome their fear and their phobia, not just for that instance, but for the longer term benefit.
Fantastic. And I think, as you say, absolutely building up that patient rapport and that trust is so important in this situation, and something that can aid that can also be helpful, but it is more all about that rapport and your understanding with the patient. Great to see some students on. Craig Smith joining in, doing a little bit of studying, getting ready for third year at GCU next year, Jackie, so I think he'll be looking forward to joining. Got a question actually coming in from Rosie Pooley, a former student, who also notes that it wasn't her that took your book. Just asking a question, and I think actually this is something that a couple of people, particularly those that are a bit more nervous around the use of local anaesthetics, sometimes struggle with. Is it okay to practice doing a tibial block on a friend or husband as long as they sign consent, or what's the best way about getting that confidence up to be able to perform that kind of procedure?
Oh, an interesting question. I would always try to advocate that doing something on a patient by mentorship, but by working with someone who can help you and mentor you and advise you, I would suggest is far better than doing something on a friend or a relative just for the sake of doing it. Off the top of my head, I am not quite sure of the ethics and the legality around about it, but it's not something that I would be endorsing. Now, if you work within an NHS setting, then of course that's possibly a much easier route to go down, is working with people that have more skills and more experience, and have more confidence and actually can help and support in an advisory and a mentorship role. I think in the private sector it's a bit more difficult, but I do know that there are some practitioners that have come across doing some of the private practitioner forums that actually would work with to mentor and support each other. They would maybe have some sessions where they want to do a technique. It might just be nail surgery and they're given a digital block and one of their colleagues hasn't done digital blocks for a while, and they would come in and they would mentor and that type of thing. And again, for blocks that they've not done, like tibial blocks. So I would suggest that is a more productive, a safer and a more ethical way to go than practicing on other people for the sake of practicing.
Indeed, and
would be my suggestion.
Ian Riley concurring with you there and pointing out that the challenge often comes in this situation that you're injecting a drug for no clinical purpose.
Yeah, absolutely. Yeah, absolutely.
And again, I think also this is a really, and you touch upon it there, that's a really good reason to be engaging with your local branch network. And also with, we've had a couple of surgeons on over the last couple of weeks, and they've all been really comfortable or all advocated getting in contact with them, so that there's always an opportunity there to go and see it being done and maybe build up a mentoree relationship there as well. So always opportunities to go and have a look. Quick comment coming through from some of the members who've signed up for the course. Norma, I've just seen yours up there as well. If you didn't get an email, please just DM us on the Facebook group. We'll get back to you there. But we also just double check your email address that you signed up to Citizen Ticket with. That's the emails that we've used. We use it through them for GDPR reasons as much as possible. So if you do have any questions, double check with that. But let's double check it because we want to make sure you can join in next week. Article coming, question from Gillian, I think. Names are sometimes back to front on here. If you, there's been some articles where the use of things like electric toothbrush or other things are used to neonate, hyperstimulate skin prior to injections. Do you have any thoughts about that? Again, it's probably linking back to that question about sprays beforehand.
Can you repeat the question again, please, Michael?
Sorry, Jackie, yeah, sorry. So really asking there about the use of things like an electric toothbrush to hyperstimulate the skin prior to injection, again, to sort of help to try and take away that nervousness and to be able to reduce the sensation around the area, site of injection.
It's not something I'm familiar with. It's not anything I've come across. I'm guessing it's the same concept, for example, as to your cold spray to provide a different type of sensation. But I'll go and I'll have a look at it and I'll try and pick it up and try and answer that a wee bit more fully over the next coming weeks or so. But I would need to go and look at it. It's not something that I'm aware of, and that's why I love these sessions, because I always learn something new.
Always bring up something for you to look at.
Yeah,
and again, actually, it's one of those things I'm really looking forward to about having it spread out over a couple of weeks. It's going to give time for people to digest it and come back with questions. And we really want to make these as interactive as possible. Again, just being on terms of the comments there from Ian Riley. Again, 3 pods come on and inject our patients. So yeah, really do just go and ask, and particularly if you are in private practice, that's where these networks really do come in useful, because I think the one lovely thing about our profession is everybody really is generous with their time when it comes to letting people come and see what's going on and being able to get that experience. And I think it only does good for us all, because the more confident we are, the more patients will believe and go to podiatrists first when they have sore feet. Jackie, one question coming through and that was asked beforehand. In fact, Ryan coming in here from one of our watch parties. In terms of nerve anatomy and nerve physiology, are there any particular resources that you think just get it spot on and make it really simple to be able to get your head around those, particularly if you do struggle with your anatomy?
Anatomy, good anatomy textbook. I mean, anatomy is anatomy, but there are some anomalies. In fact, a couple of years ago when we did the local anaesthetic day at the Royal College, Ewan McGivern gave a fantastic talk on some of the anatomical variances and anatomical anomalies in nerve anatomy, but they are there, but normally anatomy is anatomy. And I think A good anatomy textbook, and again, it depends what works for you. There are good texts there that are very visual. So if something visual works, then perhaps something like McMinn's Anatomy is a good text. I think for detail and good depth of learning, Cunningham's Manual of Anatomy, I think the most current one is 15th edition. Anatomy TV, if you can access that, those were the images that I was using tonight. Very, very good resource. Physiology and some of the pharmacology, I'll show a couple of videos next week that I sourced from YouTube that I think are fantastic. I think they make it very simple, very engaging, very easy to understand. I think what we have to understand is that we're not physiologists, so we're not trying to learn physiology of nerve to the nth degree. We're not pharmacologists, so we're not trying to learn the minutiae detail of the pharmacology of a drug. What we need to be able to do is understand how a nerve functions and understand how a local anaesthetic functions and marry up the two to actually understand what we're doing. And if we understand what we're doing, then it makes it a whole lot easier to problem solve, which is why I think that, you know, the back to basics of anatomy, physiology and pharmacology, that triad is so important. I don't know if that answers the question that's been asked. I'm happy to develop it if it doesn't.
I think it gives a really good overview, and I have to say there's some additional resources there, and I know very much for the visual learners out there, and I have to say when I started my revision all those years back, I was always slightly snobby of it, but the colouring in booklets can really help you understand the interrelation between the different structures, and can help you. And also, for those that do get the opportunity, there are some fantastic courses out there with cadaver work that have been running over the last couple of years. And again, something I know personally, a couple of the Glasgow members have been on and have come back with extremely good feedback on the ability to be able to see not just where the anatomy is, but also as many recent or certain vintage of Glasgow Caledonian students will know, the ish of anatomy and the slight variation that we see. Jackie, one last question, and then I think we'll begin to wrap up for this evening. But a couple of questions before we started came in asking about self-aspirating needles and their use within it. And I know that, particularly for those that have qualified more recently, that's probably the core that they've been using. But what's your view on the self-aspirating, and what are the certain aspects that you need to take into account when using a self-aspirating needle?
Okay, I think for me, one of the key things about injecting, regardless of what injection you're doing, two key things. One, it's safe, and two, it's repeatable. So I think what you want to do is work to a technique that you know is going to be safe, and work to a technique that you're repeating every time you do an injection. You are going through the same process, because if you get into that good practice and that good process, the risks of making errors, they reduce. So there are a lot of people that would say, well, if I use self-aspirating syringes, I don't need to aspirate. And to a degree, that's true. And certainly the ultra-safe syringes, what I would do is when I'm injecting, if the thumb is on the plunger and you then get your needle in situ and release your thumb, just because of the way it's designed, that will change the pressure and will draw any blood into the syringe if you're in an artery. So that's fine. But my question then is, what happens when you're doing something and you're using a different type of syringe and you forget to aspirate because, well, you use self-aspirating syringes and you don't go through that process? So I would always advise, and I would always try to teach, that if you're using a self-aspirating syringe, go through the process of aspirating, even if that is lifting your thumb and touching the top part of the plunger, just to go through that process of aspirating, so that is then transferable to every injection that you do. And if you're using the BD syringes, then you're in the process mentally, you're in the habit mentally of aspirating, So it's no different to what you're doing. And that would be my safety first approach on it. Now, I know from experience that actually with these self-aspirating syringes, with my thumb on the plunger, when I have hit a blood vessel, the blood will come into, the blood has come into the syringe even at that point. So they are pretty effective, but I think it's this safe, repeatable process that is key in reducing human error.
Fantastic, Jackie. Thank you very much. I think that I think we'll draw it to a close just there. We've got a lot more to cover, I know, and I'm sure everybody's already a lot of people saying they're looking forward to it, Jackie. So thank you very much, and to everybody who has joined us and is on the course, fantastic. As I say, details will be coming out at the weekend how to share, and also in the email that came out today, you should be able to join the group. If you do want to find out more and you'd like to sign up, just nip onto the Glasgow page. There's a link on one of the events, the event there, for how you can sign up. On the page, it does say it's just for the next week. It's only because Facebook wouldn't let us do it for longer, and I didn't think we wanted a month-long event. So do just click on the link, and it will take you through for the rest of details. A quick note, just on that last question from Kevin Cole, that Medicines and Medical Devices Committee recommends the Ultra Safety Plus. There, and it's always good to be able to know your guidelines and and being up to date with them, because that way if something does happen, you've protected yourself and your patients. We've got still got a lot more talks coming up, but first of all, a big thank you to, as always, the Northern Ireland, Manchester and Glasgow branches for helping us put these together, and also to the Flexitol Tomorrow's Podiatry Awards for helping support these talks. A really big thank you, Jackie, for a great session, and really whetting our appetite for the next couple of weeks going forwards.
My pleasure, Michael, and look forward